Good afternoon. My name is Jill White. I'm Emeritus Professor of Nursing and Midwifery at the University of Sydney, and I've been invited to speak with you today about 2021, two very unexpected years, and how has nursing fared through these strange times. So let me just share my screen with you. This will only take a second. So before I begin, I would absolutely like to acknowledge the traditional owners of the lands on which we meet this afternoon and pay my respects to elders past, present and emerging. I'd particularly like to acknowledge the peoples of Wiradjuri Nation, where I had the privilege of being born and bred in Indiamara. So who am I as I speak to you? Well, I met some of you just on 2 years ago at this session. Since that time, so much has happened in all our lives, some of it for wondrous and good amidst absolutely dreadful circumstances. In my life, there are these two small human beings who've been born through the time of COVID. Ollie, my grandson, born at the very beginning of COVID, and Annie, my granddaughter, born just 6 weeks ago. Absolutely steals one's understanding of the knowledge of a effective and efficient health system. When I had the privilege of speaking with you in October 2019, I was talking to you about the Nursing Now campaign and the importance of allowing nurses to work to their full scope of practice. I talked to you about the fact that there had been a report done, a global report done from the UK, that indicated that at a global level, nursing was underutilised and undervalued. And if there was any chance that we would get to be able to provide appropriate healthcare to all people in the world, that it was, yes, important about increasing the numbers of nurses, but crucially about making their contribution properly understood and enabling them to work to their full potential. And that nurses could not do this by themselves, that politicians, non-nurse leaders and others had to work with them to create the radical change that was needed in how nurses were both perceived and in what they were permitted and enabled to do. And we anticipated 2020 as a wonderful year. It was the World Health Organization proclaimed Year of the Nurse and Midwife. So we headed into 2020 for a year of celebration, for making political strides, public strides in the understanding of what contemporary nursing was about and gaining media attention. But as we know, when they said 2020 would be the Year of the Nurse, they weren't joking. It most certainly was, but not in the way we intended. Some of the work of the Nursing Now campaign with WHO, the World Health Organization, was able to continue. It was indeed the International Year of the Nurse and Midwife. And we had the first ever State of the World's Nursing report at the World Health Organization. The first time there'd been an accounting for how many nurses were at what level, educated to what level, and what the shortfall was, both now and in projection. And this led to the World Health Organization Global Strategic Directions for Nursing and Midwifery that came to the World Health Assembly in 2021, so May this year. And in that report, there was a commitment from every health minister around the world to report on what was happening in relation to nursing education, jobs, leadership, and service delivery. And so a lot of the recommendations from the Nursing Now campaign picked up in that. But of course, the World Health Assembly didn't look like this, which is what it usually looks like. Thousands of people in this fabulous venue in Geneva. It was, unsurprisingly, in 2020 and 2021 virtual. But what about in Australia? Well, I don't need to tell you the fears, the terror that we went through with the bushfires, and absolutely affecting the Murrumbidgee area as those fires came over the hills towards Batlow and Tumut and Tumbarumba particularly. And of course, no sooner did we have the fires than we were hit with COVID. So whilst nursing wasn't what we anticipated, was it what we needed? Well, just before I get into this, I just want to share with you one of the things about COVID. It did some horrendous things, but it also brought about some of the best cartoons and jokes I think I've ever seen. And this I wanted to just share with you, my very favorite. You all know about this little piggy went to market. What happened to the next one? Stayed home. Terrifying, terrifying things hit us, particularly for health professionals, where the research was not clear in the early days about the mode of transmission or what we had to do in relation to personal protective equipment to stay safe ourselves. So what did we need in a health workforce in a crisis, particularly from our nursing workforce, given that that makes up much more than 50% of the health workforce, both here and globally? So we need a workforce that's agile, we need a workforce that's trusted, and we need a workforce that's absolutely able to get the resources for the people who need them, where they need them, and when they need them. So let's just take a little look at some of these. In relation to agility, that ability to morph, to function effectively in novel circumstances. Well, one thing about nurses, we've always been agile, and that agility absolutely came to the fore as we had the scorching of the Batlow apple, as we had the floods, not all that long afterwards. And it raises the question that I think the community doesn't think about. What happens to patients and residents of health facilities when a fire or a flood approaches? Who organises evacuations? Where to? With whom? How? And when patients leave or can't leave, who stays? And the stories from the Batlow and Tumbarumba evacuation of the health services are absolutely heartwarming and heart-stirring to hear, as nurses organised for patients to come from their area to safe hospital health facilities. And that was distributed right throughout the Murrumbidgee local health district, depending on the need of the patient and the problem that they had. And some of these nurses actually went with their patients because they were unsure that the patients would be safe in environments that they didn't know, particularly dementia patients, for example. And these nurses had the opportunity to leave their work, to be with their families, but the majority of them chose to stay with their patients. True hero stuff, I think. And what happens when borders close? Well, particularly in our state, we had health services that were looked after on the southern border by Victoria and then the northern border by Queensland. And so there has to be then a rapid response to care for the people, in this instance, for the people in Albury and the surrounds, when there couldn't be any crossing of the border. And Victorian Health had been actually responsible for the care of the people in Albury. All of a sudden, it falls to Murrumbidgee Local Health District, and of course to more than nurses, but nurses in particular. So the agile workforce, well, out of the woodwork they came. When people couldn't come from across the border from other areas, we had to rely on the people that we had here. So the assistants in nursing, those who'd done the vet qualifications while they were at school, came to be helpers and runners. Retired nurses came back to give vaccinations. And so Murrumbidgee was one of the areas where all of the immunisation were given by authorised immunisers. Nurses accepted redeployment into roles they'd never dreamt of taking on before. They had to leave their substantive positions, knowing that there wasn't a backfill, so their job would still be there, mostly not being able to be done. And at times, I know that many of your nurses worked up to 3 months straight without a day off. And all the while that this was happening, patients with mental health needs, chronic disease issues, and acute care needs were all still being attended to often by virtual clinics. So nurses through the last 2 years, very different environment. From the pop-up drive-through testing clinics, sometimes pulling up in minivans on the side of the road or at a park. And I know one circumstance where they had to set up tents in a park that had no water, no toilet facilities, 40-degree heat. And day in and day out, the nurses did that testing. And in this region, in this district, over 60,000 vaccinations have been administered by your nurses. And all the while that this planning, these logistics, this resource allocation was having to happen in the background, often by nurses not necessarily in nursing positions, but who'd moved into logistics and resources and operations, there had to be the planning and the scaling up for the potential for an outbreak within the region. And we didn't know where that would be, if that would be, and what would happen. Would you have a designated hospital? It was a COVID hospital, or would every hospital have a COVID ward? And all the while, the research was constantly changing, and so the plans had to be changed. So agility, plus. Trust. Trust such that people have confidence in what's being said and done, and confident that they will not come to any harm. And nurses actually work, because of they are members of a profession, they work with a particularly professional moral compass. And I do like this description by Janice Morse, who's a New Zealander, and some of her colleagues. So the capacity to decide with intelligence and compassion, and given uncertainty in the care situation, well, that was in this case, drawing as needed on a critical understanding of the codes of ethical conduct, clinical experience, academic learning and self-knowledge, and with the ability to anticipate consequences and the courage to act. And indeed, the courage to act was shown in spades through this time. So that working with a moral professional compass is actually, for the patients, a flip side of trust. When you see this in your nurse, you have trust in that person. And that trust enables a communication that is often unpalatable in a crisis situation. And so that trust has to be established beforehand, so that you will respond immediately and with trust and goodwill in a crisis. And I have to say, for 19 consecutive years, globally, nurses have been seen as the most trusted profession and continue to be so. And indeed, we saw this outpouring last year. Flyovers, royal family clapping, Easter last year and the year before, we had more chocolates delivered to hospitals than you could ever imagine. So there was a sense in which the public started to see, in many places that particularly had COVID, what it was that nurses were doing. And indeed, even Boris Johnson, who said they were watching, they were thinking, they were caring, and they were making interventions as needed. And he saw that the two nurses he pointed out in particular were responsible for saving his life. Little skepticism on behalf of some of the British nurses. We're recording the applause to play to the government when the pandemic's over. And in fact, they're having a terrible issue in the UK at the moment with the government living up to its promises. The third most important thing then is that to be a workforce fit for the crisis, they needed also to be influential. And by influential, I mean that the workforce is heard in policymaking and successful in procuring resources. And the International Council of Nurses, based in Geneva, a group with whom I've done much work over the years, in September of 2020, did a survey of their member countries, and they found that in half the countries there was a shortage of appropriate personal protective equipment for nurses in term care facilities. And a third of nurses experienced a shortage when they were working in community settings. And I know this happened in Australia. For many of the privately practicing nurse practitioners, they found great difficulty in being able to obtain appropriate PPE. And in fact, it took in Australia until June this year that there was an agreed protocol in relation to personal protective equipment. So the gowns, the masks, the shields, yeah. that need for a particular sort of mask that was fit tested for the face, because masks don't fit all faces in the same way, for people working in high-risk areas. And we know that this lack of PPE has had consequences. We know that this is a very conservative estimate from the World Health Organization, that over 115,000 healthcare workers, and remember nurses make up more than half of these, have died during the pandemic. So that safe working environment, absolutely first priority, including the staffing level. So how many nurses to how many patients, that's been delivered by research from Queensland. And Tim Porter O'Grady, who's written a lot about leadership and leadership in nursing, says that nurses at all levels should see that policy and politics, that it's something that they should be obliged, I would say, he said, obligated to shape, rather than something that just happens to them over which they have no control. And indeed, this is now recognised by nurses who used to think that their only concern was the nurse-patient relationship. What did I need to do for my patient, the nurse-patient relationship, without thinking or realising that, in fact, everything that they could do with their patient, their facilities, their resources, their work allocation, was determined by health services, which in turn were constrained by enabled by ministries of health, by government decisions, by national decisions, and indeed by things that happened at a global level. And so nursing input throughout these layers was absolutely critical to, in fact, being able to function with the patient at the bedside. And so nurses have always been good at seeing the detail of the immediate surrounding, the immediate needs of their patients, the circumstances of their patients, but they've been less aware of the need to see far, to see over the horizon what might be coming, what are the logistics tracks to be able to get what I need, who's making decisions about what it is that I need for my patients, who's giving advice, and other things that I know being included in that advice to government. And so in our area, we have enrolled nurses, we have registered nurses, you have a growing number of nurse practitioners, and absolutely came to the fore through COVID, and interesting, a greater recognition by the medical profession of the collaborative way in which they can work with nurse practitioners rather than feeling that they were a threat in any way, in all sorts of circumstances, but not always able to work to their full scope of practice. And I just want to remind you of what we saw earlier from the Nursing Now report, from the Triple Impact report, where they said it is about making sure the contribution is properly understood and enabling nurses to work to their full potential. Politicians, non-nurse leaders and others must work with them to create radical changes in how nurses are perceived and in what they're permitted and enabled to do. And some of the things that prevent nurses from doing this, some of it's legislation, some of it's regulation, some of it's just local policy, some of it's myth, some of it's culture, a lot of it's turf protection, and some of it's benign neglect. And so in many ways, it's up to nurses to get on and do something about it, but we need your help. And in fact, these days we're finding nurses everywhere. We're finding we've got a current in Wollongong, our Vice-Chancellor, the Deputy Secretary of Health, Susan Pearce, is a nurse, the Federal Secretary of the largest union in Australia, Annie Butler, is a nurse. One of the faces you've seen very recently, Julie Leask on drum and many other things, a World Health Organization advisor on vaccines, is a nurse. Your own CEO has a nursing background, as have half of the CEOs of local health districts in this state. And we have most local health districts have a senior nurse as a board member. And Mary Curella, you may in fact have seen before as a frequent commentator on the drum. But we also at the moment have two nurses in federal politics. We've got Jed Carney and the wonderful Helen Haynes, the independent member for NDI, who's really pushing that independent commission on corruption. So we now have nursing absolutely still committed to that absolute nurse-patient relationship at the bedside, but also trying to do more for the over the horizon things, making policy at a more senior level. So we need nurses at every one of these levels, and we are starting to get there. And why do we need them? Because they hold your cumulative story of your experience of health and illness. They're a bridge between you and the health system. And so they're critical to policy. So looking for a career change, either for you or one of your children, do I have the future for you? So thank you very much. It's been a wonderful opportunity to talk with you again today. So thank you. Thank you to the nurses of this district. And thank you to Julian Clift, Carol Dallinger, and Denise Garner for sharing their stories with me. I really appreciate it. And I hope to see you soon. Bye.